Chronic pancreatitis. Chronic pancreatitis is a inflammatory disorder characterized by progressive anatomic and functional destruction of the pancreas. As cells are replaced by fibrous tissue with repeated attacks of pancreatitis, pressure within the pancreas increases. The end result is mechanical obstruction of the pancreatic and common bile ducts and the duodenum. Additionally, there is atrophy of the epithelium of the ducts, inflammation, and destruction of the secreting cells of the pancreas. Alcohol consumption in Western societies and malnutrition worldwide are the major cause of chronic pancreatitis. Long term alcohol consumption causes hypersecretion of protein in pancreatic secretions, resulting in protein plaques and calculi within the pancreatic ducts. Alcohol also has a direct toxic effect on the cells of the pancreas. Damage to these cells is more likely to occur and to be more severe in patients whose diets are poor in protein content and either very high or very low in fat. Clinical manifestations. Chronic pancreatitis is characterized by recurring attacks of severe upper abdominal and back pain accompanied by vomiting. Attacks are often so painful that opioids, even in large doses, do not provide relief. As the disease progresses, recurring attacks of pain are more severe, more frequent, and of longer duration. Some patients experience continuous severe pain, others have a dull, nagging, constant pain. The risk of dependence on opioids is increased in pancreatitis because of the chronic nature and severity of the pain. Weight loss is a major problem in chronic pancreatitis. More than 75% of patients experience significant weight loss, usually caused by decreased dietary intake secondary to anorexia or fear that eating will precipitate another attack. Malabsorption occurs late in the disease when as little as 10% of pancreatic function remains. As a result, digestion, especially of protein and fats, is impaired. The stools become frequent, frothy, and foul smelling because of impaired fat digestion, which results in stools with a high fat content. This is referred to as steatorrhea. As the disease progresses, calcification of the gland may occur and calcium stones may form within the ducts. Assessment and diagnostic findings. ERCP is the most useful study in the diagnosis of chronic pancreatitis. It provides detail about the anatomy and pancreas and the pancreatic and biliary ducts. It is also helpful in obtaining tissue for analysis and differentiating pancreatitis from other conditions such as carcinoma. Various imaging procedures, including magnetic resonance imaging, MRI, computed tomography, and ultrasound, have been useful in diagnostic evaluation of patients with suspected pancreatic disorders. Computed tomography scanning and ultrasound is useful to detect pancreatic cyst. A glucose tolerance test evaluates pancreatic islet cell function, information necessary for making decision about surgical resection of the pancreas. An abnormal glucose tolerance test indicative of diabetes may be present. In contrast to the patient with acute pancreatitis, serum amylase levels and white blood cells count may not be elevated significantly. So, assessment diagnostic findings from ERCP, MRI, CT scan and ultrasound, and last one, glucose tolerance test. Medical management. Treatment is directed toward preventing and managing acute attacks, relieving pain and discomfort, and managing exocrine and endocrine insufficiency of pancreatitis. Non-surgical management. Endoscopy to remove pancreatic duct stones and stent strictures may be effective in selected patients to manage pain and relieve obstruction. Non-opioid methods to manage pain, and the third one is importance of avoiding alcohol and other foods that the patient has found tend to produce abdominal pain and discomfort. Pancreatic enzyme replacement is indicated if the patient with malabsorption and steatorrhea. Surgical management. Surgery is generally carried out to relieve abdominal pain and discomfort, restore drainage of pancreatic secretions, and reduce the frequency of acute attack of pancreatitis. Pancreaticojejunostomy. 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 With a side-to-side anastomosis or joining the pancreatic duct to the jejunum allows drainage of the pancreatic secretions into the jejunum. Pain relief occurs by 6 months. Is more than 80% of patients who undergo this procedure, but pain returns in substantial number of patients as a disease itself progresses. Other surgical procedures may be performed for different progress and type of disease, ranging from revision of the sphincter of the ampulla of water to internal drainage of the pancreatic cyst into the stomach, to insertion of the stent, to wide the resection or removal of the pancreas, a Whipple resection, that is pancreaticojejunostomy. Autotransplantation or implantation of the patient's pancreatic islet cells has been attempted to preserve the endocrine function of the pancreas in patients who have undergone total pancreatectomy. When chronic pancreatitis develops as a result of gallbladder disease, the obstruction is treated by surgery to explore the common duct and remove the stones. Usually the gallbladder is removed at the same time. In addition, an attempt is made to improve the drainage of the common bile duct and the pancreatic duct by dividing the sphincter of Oddi, a muscle that is located at the ampulla of water. The surgical procedure known as a sphincterectomy. Sphincterectomy is SPHINCTEROTOMY. Sphincterectomy. A T-tube usually is placed in the common bile duct, requiring a drainage system to collect a bile postoperatively. Nursing care after surgery is similar to that indicated after the biliary tract surgery. Patients who undergo surgery for chronic pancreatitis may experience weight gain and improved nutritional status. This may result from reduction in pain associated with eating rather than from correction of malabsorption. However, morbidity and mortality after these surgical procedures are high because of the poor physical condition of the patient before surgery and the concomitant occurrence of cirrhosis. Even after undergoing these surgical procedures, the patient is likely to continue to have pain and impaired digestion secondary to pancreatitis unless alcohol is avoided completely. So, surgical procedures: pancreaticojejunostomy. Next one, Whipple's resection, that is pancreaticoduodenectomy. 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 And the third one is sphincterectomy. SPHINCTEROTOMY. Thank you.